Now, the functional unit here is the nephron. The nephron consists of the glomerulus, which is blood flow. This is arterial blood flow that comes into the glomerulus through the afferent, A meaning before, right? Afferent arteriole. And then the efferent arteriole takes the blood away from the glomerulus, and then it goes around the distal and the proximal tubules and loop of Henle, etc. So that cascade of vessels meets up with the vein as well, and there's capillaries that are formed that do the dirty work of the kidney, right? The functional work of the kidney. The nephron itself starts the process of urine formation by sending blood to the afferent arteriole that goes to the glomerulus, and then the glomerulus just spills out essentially plasma, right? It essentially just dumps plasma into the collecting duct, the beginning of which is called Bowman's capsule. And Bowman's capsule then leads to the proximal tubule. And the proximal tubule is surrounded by all this capillary system where all the busy work gets done. Then the proximal tubule gives rise to the loop of Henle, the proximal loop, the distal loop, and then it goes to the distal convoluted tubule, where again it's surrounded by this capillary structure, and then the urine gets formed into the collecting tubule. So the filtrate, we refer to the filtrate as the stuff that gets dumped from here, almost essentially plasma, that gets dumped directly into Bowman's capsule. That's the filtrate. And then that goes through this duct, and by the time it gets to here, it's urine. But there's a lot of steps in between. I'm going to show you those steps. So the glomerulus uses these pressures that we just talked about. It uses the hydrostatic pressure, that's the blood pressure, right? And it uses the colloid osmotic pressure, or the oncotic pressure, to regulate the fluid movement at Bowman's capsule. And so the net filtration pressure is the glomerular hydrostatic pressure, that's the blood pressure at the glomerulus, minus the Bowman's capsule pressure, minus the glomerular oncotic pressure. All right? All of those together are used to calculate the net filtration pressure. And that tells us how much urine gets formed. So glomerular filtration is also known as the GFR. And so the GFR is this complicated formula here, but at the end of which we get a glomerular filtration rate in milliliters per minute. It's a difficult thing to measure, right? We don't really have a way to measure it, so we need to estimate it. Well, there's a ton of different ways to estimate it, but the one that we tend to use the most is this formula that they came up with in the Modification of Diet in Renal Disease study, or the MDRD study. And in that study, they took into account a whole lot of things. So let me just back up and explain to you that, you know, if we're going to just do a spot check of the kidneys, and I want to know how healthy my kidneys are, I'm going to look at what number? I'm going to look at the creatinine, right? That's the spot check that we use. And we use it in the hospital, and we follow it along, longitudinally, because it gives us an idea about somebody's kidney function. But somebody who's big and muscular, like me, right? Just kidding. But somebody who's big and muscular has a much higher creatinine because they're processing more protein and more protein breakdown than a little old lady who doesn't walk and is bedbound with very low muscle tone and very low muscular content. So how can I look at my creatinine and her creatinine next to each other and know that, know which one of us has better renal function? Or if we both have a creatinine of 1.1, what does that mean? If I have a creatinine of 1.1 and I'm a muscle-bound bodybuilder, that's probably pretty good, right? But if I'm a little old lady who's lying in bed and has no muscle mass, a 1.1 creatinine is probably dangerous. And in fact, I had this very thing happen just last week at work. I had a 90-year-old woman who had a creatinine of 1.2, and I told her, I'm concerned about, she came in with chest pain. Turns out it was the real deal. She definitely was in need of catheterization, but I didn't want to kill her kidneys. So I said, I'm concerned about this because, you would have a high chance of needing dialysis after catheterization. She said, but I don't understand. I didn't know that my kidneys were no good. I said, your kidneys are fine, but you have 90-year-old kidneys. Your creatinine is 1.2, not awful, but when I did the math that this equation provides, I could tell that she had very poor kidney function. Her GFR was around 35. And giving her a dose of IV contrast had the potential to lead her to dialysis. So I tell you that story because a creatinine of 1.2 doesn't make people always look and worry. But when you do the math that's taken into account by this GFR calculation, it makes sense. So it is a function, the GFR is a function in this equation of the age, the serum creatinine, and by the way, it has to be a stable serum creatinine. This is not a calculation that you do during an acute renal failure episode. So stable creatinine, the BUN, the albumin, because that's a function of it too, the sex, and the race, because we know that blacks tend to have higher serum creatinines than whites. And so we plug all that in and we turn the crank and out pops a number, and that number is the GFR. We're going to use the GFR later on today when we talk about the levels of chronic kidney disease. Now I want to get back to talking about the urine and the filtrate and all that jazz. I don't expect you to memorize this, but I want you to appreciate all the stuff that's going on in the kidney, all right, during the production of urine. So first of all, you should know that 2/3 of that filtrate, again, which is mostly just raw plasma, about 2/3 of that filtrate ends up getting reabsorbed back again in the proximal tubule. Well, let's just trace what happens in each segment of the nephron and see what's going on with the concentration of each of these things that's in the filtrate, all right? Or what will become urine by the time we get to here. So when we first dump all this stuff out, we have a concentration that is about equal in amino acids, glucose, proteins, bicarb, potassium, sodium, chloride, creatinine, and urea, right? So they all come out here at a concentration of 1. But during their transit through the proximal tubule, the capillary system pulls stuff out and adds stuff back in. Well, what it pulls out is the glucose, the protein, and the amino acids, because we don't want that stuff going out and getting lost in the kidney or in the urine. So we want to reclaim that stuff, and that's the job of the proximal tubule. It reclaims a huge portion of the glucose, protein, and amino acids. It also reclaims a decent amount of bicarb, but remember, the kidneys have to balance the amount of bicarb that's available. That's a really important function of the kidneys. to maintain acid-base balance. And to maintain acid-base balance in certain conditions, it needs to hold on to more bicarb, and in certain conditions, it needs to get rid of more bicarb. Not much happens to sodium and potassium, but look what happens to creatinine. The proximal tubule actually takes that concentration of creatinine and adds to it. It actually adds more creatinine back in. And same with urea. Okay? Get to the loop of Henle, and this is where the sodium and potassium really start to change, right? Along with the chloride. And you know that because this is where loop diuretics work. And we know that when we use loop diuretics, we lose a ton of potassium. And the reason that the diuretic works is because we lose a ton of sodium. Along with sodium moves fluid, right? Moves water. So that's what's going on in the loop of Henle. But look what else happens here. This huge increase in the amount of urea that gets into the filtrate. And that just keeps going up. So that blood urea nitrogen, or the urea, continues to increase in concentration in what becomes the urine by the time it gets here. Okay? Now, after the loop of Henle, there's or in the second half, in the ascending loop of Henle, there's a sudden decrease in the concentration of sodium and potassium because the loop of Henle says, whoa, we got to hold on to this stuff. We can't dump it all. You know, we got rid of some urine. That's good. But now we got to reclaim some of the sodium and potassium. And so that's what happens here. But remember, the job of the kidney, in addition to many other things, is to get rid of potassium. So when it gets to the distal tubule, that's where the majority of this potassium is lost, in the distal tubule and the collecting tubule. Okay? So that is how the urine is formed. Again, I don't expect you to memorize this, but I want you to have an appreciation for the fact that in the proximal tubule, there's reabsorption of glucose, protein, and amino acids, because those things we don't want to get rid of. We want to keep them in there, except when we talk about certain drugs like SGLT2 inhibitors, where we want to spill glucose here, but that's for later on. All right. And then the other thing is that we want to get rid of creatinine and we want to facilitate loss of urea throughout the rest of the kidney. And that's what happens here. So in the proximal convoluted tubule, all these actions are happening. Now, remember, it takes ATP, right? It requires energy for the sodium potassium pump to work. The glucose comes out. Remember, it's being reabsorbed from the filtrate, gets reabsorbed and goes back into the bloodstream over here. Same with amino acids, same with bicarb, same with some of the water, same with some chloride. All of those things are happening in these renal epithelial cells. Okay, those are the cells that line the renal tubules. Remember I talked about SGLT2, right? There is a specific kind of diabetes and, by the way, heart failure drug called an SGLT2 inhibitor. And what that does is it works to decrease the function of the SGLT2 site in the proximal tubule. And it makes the kidney hold on to, makes the filtrate hold on to sodium and glucose. So these patients tend to pee out more, and a lot of the glucose that would otherwise end up back in their bloodstream, right here, ends up in the urine. So the SGLT2 receptor is responsible for pulling out sodium and pulling out glucose and putting them back into the capillary. And the way that the SGLT2 drugs work, SGLT2 inhibitor drugs work, is by blocking this mechanism, okay? And they get rid of more sodium and glucose that way, which is great for heart failure. It's great for diabetes, and it's great for diabetics who happen to have heart failure, right? That's like even the best thing. Now remember that bicarb is the most important component in acid-base regulation. It takes a long time for it to start to work, but when it works very powerfully. And bicarb reabsorption is an important component of maintaining acid-base balance. So I'll let you read this stuff on your own, but essentially what's going on here is that this bicarb comes into the filtrate, mixes with hydrogen ions, right? Because it's going to take care of any acidemia that exists. And so the hydrogen ions come out of the bloodstream and go directly in. Where is it? I don't see it on here. But in any case, the hydrogen ion, oh, it's from this reaction here. So the hydrogen ions come off of here from the carboxylate and go into the filtrate where they mix with the bicarb, and then that becomes H2CO3. And that then comes back in. We can mixes with CO2. Changes into water and CO2, and then it continues this reaction that we're going to talk about more with the acid-base balance. But this happens in the renal tubule, and is a very important component of acid-base balance. Remember, the kidney has a major role in getting rid of excess potassium. Potassium cannot float around freely in the bloodstream because it's bad for you, right? We want potassium to be intracellular where it can't do any harm. But once the cells are full of potassium, they don't want any more, then the potassium floats around in the bloodstream and does things like make your heart stop. That's not so good. So the kidney's job, among others, is to get rid of that potassium. And the way that it does it is by secreting that potassium, again, through the sodium-potassium pump in the renal cells. And then that potassium gets dumped into the lumen here, and it disappears in the urine. Another important thing that happens then is ADH, the effects of ADH on water, right? So all the other stuff that we talked about, there's electrolytes that are pushing water around. Well, in this case, we have ADH that's doing the work. And so what happens here is that the ADH molecule hooks up to vasopressin 2, right? The vasopressin 2 receptor creates a second messenger then, cyclic AMP, that goes to the aquaporin 2. Goes to aquaporin 2. Aquaporin 2 then facilitates the movement of water from the collecting tubule back into the bloodstream. And that is the way that antidiuretic hormone maintains fluid volume in the blood.